Good afternoon. I'm Russell Wooldridge, and I'm pleased to welcome you to the latest in our DRI webinar series. It is our hope that DRI's webinars will be used as a platform to encourage dialogue on current and emerging issues, as well as to provide knowledge and education in unique areas of the business continuity arena. Our goal, as always, is to explore the material and provide you with a thorough understanding of the topic at hand. Today's webinar explores business continuity in the healthcare sector, with lessons continuity professionals can apply in every industry. Faced with regulatory requirements, increasingly complex technology, ransom attacks, and the Zika virus, continuity professionals in healthcare certainly have their hands full. Discussing these topics are today's speakers. Mike Mastrangelo, Program Director for Institutional Preparedness for the University of Texas Medical Branch at Galveston. James Mitchell, Assistant Director at Texas Children's Hospital. Brad Gare, Vice President of Emergency Management and Enterprise Resilience at NYU Langone Medical Center. And John Molnar, Managing Principal at Integrity Consulting and the DRI International Healthcare Lead Instructor. If you have any questions, please feel free to submit them at any time. Then, after our speakers are done with their presentations, at about the 1 hour mark, we'll tackle the Q&A. Please use the question box in most cases at the bottom of your control panel on the right-hand side of your screen. Simply type in your question at any time during the presentation. Address it to all panelists, and we'll respond to as many of them as we can during the question and answer portion. We also request that you keep your microphones on mute through the presentation, which can be checked by your name at the attendee screen in the right-hand column. Now, let's hear from our experts in the field. First up is Mike Mastrangelo. As Program Director for Institutional Preparedness at the University of Texas Medical Branch at Galveston, Mike is responsible for all aspects of preparedness, including business continuity. Mike, can you tell us about how you and your organization address today's risks?
Thank you, Russell. First, I'd like to put the overall question in a broader context and talk about what healthcare continuity means in our current evolving environment, and also to address the expanding role for the continuity professional in the healthcare industry. What is healthcare continuity? There's an increasing expectation that hospitals are going to remain open and ready to serve patients in a disaster. And then hospitals need to be resilient and able to adapt to novel disease outbreaks and emerging infections like Ebola viral disease or Zika. So both of these imply a robust healthcare continuity planning. So contemporary healthcare continuity planning goes well beyond the technology, information technology, disaster recovery planning, and departmental BCPs for traditional business functions like accounts payable, accounts receivable. There's also a greater need, I believe, in the need for integration with emergency management and risk management. I think there's some important concepts in regard to meeting this higher expectation. One of these concepts is the idea of a healthcare coalition. If you're going to have robust continuity plans, you basically need to be part of a strong healthcare coalition. And that basically is a group of healthcare organizations, public safety and public health partners that join forces for a common cause in making their communities safer, healthier, and more resilient. There is, in fact, a national program. It's administered through Health and Human Services that encourages the development of healthcare coalitions. And in fact, the hospital preparedness program is built around that framework. Here at UTMB in Galveston, we're part of the Southeast Texas Healthcare Coalition. Its actual name is Southeast Texas Regional Advisory Council. It's a very strong coalition. We're a key partner to that coalition. And for example, CETRAC, or our Healthcare Coalition, and UTMB developed a regional Ebola patient transport plan, and this was subsequently adopted by the state of Texas and then by Health and Human Services Region 6, which is the 5-state region, including Texas. Another key aspect of our response to disease outbreaks, or Ebola or Zika in particular, is that we're an academic health center and we have a national laboratory. And so our healthcare coalition is strengthened by this fact. And academic health centers in general play a particularly important role in regional healthcare coalitions. So, in addition to being an academic center, we have that national lab, and they assisted the state of Texas, for example, back in the H1N1 outbreak in screening specimens when the state lab quickly developed a backlog of several thousand specimens. The throughput at the Galveston National Laboratory was 1,000 specimens per day. So we were able to help them address that backlog. In terms of Ebola, the GNL has assisted the response to that through such activities as training scientists, developing diagnostics, and developing therapeutics. So in general, the GNL, or Galveston National Laboratory, has expertise in working with live select agent disease agents. And so two of the main areas of expertise needed for any kind of a novel disease response are biosafety and infection control. And these are probably two words that need to be in the glossary for every continuity in the healthcare industry. They should know it and have programs to address this. So in terms of biosafety, this includes the effective use of personal protective equipment. You know how important that is in an Ebola response. And then infection control, basically preventing the spread of the disease among patients or the healthcare staff. And so, for example, here at the Galveston National Laboratory, they've been working with live Ebola agents for many years, doing actual medical procedures while in full PPE. So they're an excellent source of information and training on proper use of PPE in disease outbreaks. And in fact, we have a national program that's used to train scientists and other healthcare professionals in proper PPE use. Let me continue and say that, for example, specific to Zika, this is a very timely disease that we could talk about. In terms of UTMB's involvement, the National Lab, the Galveston National Lab, has been involved in Zika research for many years. In fact, UTMB's reference center has the world's largest collection of Zika isolates, or in essence, samples of the Zika virus. So that is useful in the research that's needed to be done for that particular disease. So we have a number of researchers who are working on developing animal models for research in connection to the microcephaly and Guillain-Barré syndrome that you see as some of the major results of a Zika infection. Research includes development of better diagnostics. Ultimately, UTMB, Galveston National Laboratory, as well as many other organizations, are working on developing a vaccine. In terms of the support provided to countries with an outbreak, one of the principal methods that Galveston National Laboratory uses is training scientists in those regions in doing research and also biosafety. In terms of our local response, the lab has basically been doing some of the mosquito testing for the Houston area until the Houston lab, the Houston Public Health Lab, can ramp up their capabilities. And so right now that transition is going on. And that's mostly for vector control. In other words, how do you best identify that you have that particular disease vector or mosquito in a specific region, and then therefore what are the best strategies to take in terms of controlling it. The other area clearly, as I mentioned before, is biosafety training. So in particular here at UTMB, how have we in the continuity field been involved in this? One is in the distribution of health alerts, and that's basically giving information that comes from the public health arena to our practitioners, and one of those messages is being sure to consider Zika in the differential diagnosis when the patient presents with a febrile rash, doing healthcare workforce and laboratory and protection, in other words, again, infection control and biosafety, providing information examples that physicians can use when communicating with patients, and then working with NGOs in the community or non-governmental organizations in the community for community awareness. We need to maintain good communications with public health, especially in regard to reportable conditions. So these are any number of conditions that public health requires. If we see a case or a suspect case, that we report that to the public health so that they can maintain situational awareness and, if necessary, develop some kind of countermeasure program if there's a specific disease that's cropping up in the community. And then keeping up on the latest recommendations from the state, we call it Department of State Health Services. In other states, it might be called the State Department of Health. And then for other hospitals out there, CDC is a great source of information. They have information that's specific to healthcare professionals and laboratorians. So it goes into much more detail than the typical information you might hear over the media that's generally aimed at the general public. And Russell, you had also asked about some of the other timely risks that we're dealing with, and I did want to address your question about cybersecurity. I think we're in a new operating environment. This is in addition to the increased expectations on our availability in disasters. I think every hospital out there who has Joint Commission accreditation is familiar with the term priority risks. Basically, we have to do a hazard vulnerability analysis every year where we look at natural hazards, we look at risks associated with technology or deliberate acts. But we have to go beyond that and essentially, with our leadership, develop a priority so that we can actually point to what's our number one priority risk. And then we have to develop plans and other contingencies for that. So one of the big ones that we're dealing with right now is this cyber threat and ransomware. Quite a few hospitals have been hit with this since the beginning of the year. One way that UTMB is approaching this is by blending some principles from the Hospital Incident Command System, or HICS, and the field of enterprise risk management. So if we know, for example, that we're being attacked, one of the concepts that we want to use is we want to have an institutional response to that. And so we did, in fact, do one ransomware exercise recently. And one of the key goals there really was to optimize who would be represented on that incident command team if we were to receive, for example, a ransomware attack. For example, we included our continuity planning staff, emergency management, risk management, healthcare quality, our information systems, including healthcare information management, information security, compliance, police, finance, and then legal affairs. And this sort of mirrors that enterprise risk management approach. So these are some of the key actors that would actually be convened for a command center if we were to undergo any kind of ransomware attack. We included in that group insurance specialists. UTMB has got insurance for cybersecurity issues. And so I think one of the real key aspects for an effective response is if you do have insurance, know what that insurance covers, know, for example, where pre-approvals are required, know what the requirements of the policy are, because that may help shape your response, and then make sure that a cyber or ransomware incident could really be an expensive undertaking. And so if you can get insurance reimbursement for that, it would really help your organization. Just to kind of conclude, I wanted to try to put everything in the framework of what is this evolving definition of continuity planning for the healthcare industry. And I hope I've done that, so thank you.
Thanks, Mike. Joining us now is James Mitchell, Assistant Director of Texas Children's Hospital. James, tell us a bit about how your hospital responds to the current issues like Zika and ransomware.
Thank you, Russell. What I would like to do is begin by providing a brief overview of Texas Children's Hospital Emergency Management and our Business Continuity Program. Texas Children's, with over 600 beds, is the largest children's hospital in the United States. It includes a primary location in the Texas Medical Center in Houston, Texas, as well as community hospitals in The Woodlands, Texas, and Katy, Texas, in addition to over 60 Texas Children's Pediatrics offices, several Texas Children's urgent care locations, and 2 community health centers. As a whole, Texas Children's has a staff of just over 11,000 across all of these locations. As with most hospitals, Texas Children's has a fairly mature, long-standing emergency management function that is tasked with creating and exercising plans for a wide range of threats as defined within our annual Hazard Vulnerability Assessment. However, in 2013, the organization began to realize that more needed to be done to ensure our preparedness and ability to continue operations. An outside consultant was engaged who led a process to establish an enterprise-wide business impact analysis, and this was followed by an enterprise-wide business continuity plan. By early 2015, it had become apparent that to be effective, business continuity should be fully integrated into the normal operations of the hospital, and in particular, it needed to be unified with the existing emergency management structure. Today, I manage both the business continuity and emergency management teams. Each team is responsible for coordinating planning and exercises within their unique disciplines. However, most importantly, these teams work together to share information and planning activities. Business continuity provides an understanding of underlying business processes that is rarely available to emergency management practitioners, and emergency management provides a wide range of response options and continuity activities that already exist and are in place to support business continuity as a whole. In my view, the greatest challenge facing healthcare continuity professionals is that of educating staff and leadership to the value of business continuity and how it enhances but is differentiated from other disciplines. As noted earlier, many hospitals have fairly mature emergency management programs, as this is driven by regulatory requirements. Further, many hospitals also have mature information technology disaster recovery programs in place with clear processes for escalation of incidents, as well as similar processes within security and facility. With all of these programs competing for attention and resources, it can often be difficult to explain not just the added value of business continuity, but rather the fact that business continuity provides a framework that can draw together and unify these disciplines into a holistic approach that both deepens and broadens organizational preparedness. Closely related to the challenge of explaining value is also making the case that regulatory compliance does not equate to preparedness or resilience. In too many organizations, the focus is on the requirements of various regulatory bodies such as the Joint Commission, CMS, etc., rather than analysis of the risks and risk appetite of the specific organization and allowing that process to drive the planning process. While regulatory compliance is essential, preparedness must go beyond minimum requirements and be tailored to the specific organization. A good example of this is the ongoing and growing threat from ransomware, which drives home the point that we must have a holistic and integrated approach to business continuity. At Texas Children's, there's excellent work being done to defend against and prepare for cyber threats of all sorts, including ransomware. Yet, as with most organizations, that excellent work occurs within a silo that is well managed and mature, but a silo all the same. We are working at this time to review information security responses with the intent to integrate that response into a broader framework that is capable of managing the organizational impact of these threats, in addition to the IT security response. For example, how do we continue operations if a critical IT system and possibly its disaster recovery solution are both unavailable? How do we communicate with leaders and impacted business units throughout the incident? How do we draw on organizational resources as a whole and deploy those resources quickly and efficiently? All of these questions can only be addressed properly when business continuity integrates at some level all of the response processes that exist in the organization. Another example is our response to the Zika virus. This nicely illustrates the transition from threat-specific responses to impact-specific responses. During the Ebola crisis, Texas Children's created its Special Isolation Unit at our West Campus in Katy, Texas, with Ebola specifically in view. However, with the subsidence of Ebola as a threat and the rise of other emergent pathogens, the focus has shifted to addressing all threats that have a similar profile, such that planning only requires minimal adjustments rather than a completely new plan for each threat. This shift will enable us to be faster and more responsive to new threats as they arise. So finally, the question then arises, what exactly can healthcare professionals learn from those in other industries, and what can those in other industries learn from us? Having worked in investments, energy, and healthcare, I can say that each industry has its strengths and weaknesses. Investments tends to be very strong in IT disaster recovery and cybersecurity. Energy tends to be very strong in the protection of physical assets. Healthcare, however, faces all of these threats with the impact to patient lives and a vital community service on the line every day. While healthcare can learn much from other industries to create more mature business process maps and incident response models, other industries should look to healthcare for mature emergency response models, as these within healthcare are not simply an afterthought or a nice-to-have item, but instead they are essential to the delivery of critical, life-saving services.
Thank you, James. Next is Brad Gare, Vice President of Emergency Management and Enterprise Resilience for NYU Langone Medical Center. Brad is here to talk to us about Langone's resilience program, how it was impacted by Hurricane Sandy, and what it means to be DRI's first designated hub of resilience.
The program at NYU Langone Medical Center related to resilience is new post-Hurricane Sandy. Prior to Hurricane Sandy, we had a small emergency preparedness program, very similar to what you might find at most academic medical centers, with a couple of people focused mainly on hospital emergency preparedness. After Hurricane Sandy, I was brought on board to create a much more broad resilience program, and that's what we've spent the last couple of years doing. So what we have is really a two-pronged approach. We have our traditional emergency preparedness side of the operation, and then we have a business continuity and resilience part of our program. And right now our staff is focused on both of those. It's really important that we've integrated those two programs to make sure that they are effectively supporting one another, so that it's not just the emergency managers doing preparedness and the resilience and business continuity people working separately. They're working together on this. And the goal is to really provide our entire enterprise, which consists of several hospitals, a couple hundred research labs, and dozens of faculty group practices, which are basically doctors' offices and clinics out in the community, with a comprehensive resilience umbrella to make sure that we're prepared for and able to withstand any sort of typical disaster that may happen to us, regardless of scale, type, or complexity. We feel like we're getting in a good position to be able to respond to those. So in a nutshell, that's the basics of our program here at NYU Langone Medical Center as it stands today. Hurricane Sandy did a tremendous amount of damage to NYU Langone Medical Center. We're situated in Manhattan in New York City, right on the East River, and prior to Hurricane Sandy, the year before, we had Hurricane Irene, which had been expected to have some significant impacts on our area. Hurricane Irene did not. It really had more effects upstate and in some of the New England states. So we had evacuated the hospital and taken a lot of measures to prepare for Hurricane Irene, and then nothing really happened. So when Hurricane Sandy was coming along, the city actually ordered an evacuation of the zone that we sit in. However, the mayor, because of what happened the prior year, exempted hospitals from the evacuation. So we had made the decision not to evacuate. And then, of course, when Hurricane Sandy struck, the impacts were very significant, and we had a lot of water come into our facility, lost power, tremendous amount of damages, and all in all, it was a couple $2 billion worth of damages to NYU Langone Medical Center, which affected our hospital operation, it affected our research operation, it affected the School of Medicine. So there were really tremendous amounts of damages, and it took a long time to get everything back to where it should be. So the impacts were extreme. We're right alongside another major hospital, Bellevue Hospital, which is more or less city-owned. And then adjacent to that is the VA hospital. So we're in an area called Hospital Row with three major hospitals side by side, all of which had significant impacts from Hurricane Sandy, and all of which were for various times out of operation. So what we learned from that was that if you're going to be in a very flood-prone area, you need to be much more resilient. Fortunately, between our insurance that we had in place and the FEMA programs, we were able to come back much stronger than we had been before. FEMA has some very good post-disaster programs for governments and private nonprofits related to infrastructure. Basically, the way their program works is for your eligible damages, every dollar that they give you to repair, damage, or restore a facility, you can get another dollar just for resilience. So we have hundreds of millions of dollars of damage, and we receive then, in addition to that funding, hundreds of millions of dollars to make ourselves more resilient. What that's allowed us to do is to create a flood barrier to the 500-year flood level, plus 2 to 3 feet of freeboard on top of that. And we've moved all our critical infrastructure well above the area of impact in any foreseeable storm. And we've built a cogeneration plant, so we'll actually be able to generate our own power in a disaster. That was in the works prior to Sandy, but we've been able to make all that much more resilient now post-Sandy. So from a Hurricane Sandy perspective, definitely a lot of lessons learned, definitely a whole new focus on resilience that we never had before. I wasn't here at the time of Sandy. I was working for New York City in the aftermath of Hurricane Sandy on disaster recovery. But when NYU Langone decided to make a real commitment to resilience, I was brought on board. I brought a whole staff on board, and we've put together a whole program that focuses on resilience, not just physical infrastructure, but also creating a more resilient workforce, developing plans that actually can be implemented in the case of a disaster of this type, and making sure all of our processes are resilient. So whether it's our supply chain or the way that we deliver our services, we want to make sure that everything is resilient as possible in as comprehensive a manner as possible. NYU Langone Medical Center is the first to earn the prestigious DRI Hub of Resilience Award. First of all, the DRI Hub of Resilience program we feel is an important credential to have because it does demonstrate a commitment to resilience. Having said that, it really doesn't mean much if we're the only hub. So we were the first one to be awarded this credential earlier in 2016. But unless we get dozens of other healthcare facilities and hopefully one day hundreds of other businesses in different types of critical infrastructure involved in the program, it doesn't mean anything. So we're glad to be a pioneer in this, but we're also encouraging lots of others to join us. What it means to us to be a hub of resilience is that we're not only committed as a corporation to being internally resilient, which we are, but we're also very much committed to promoting resilience in the community, across the city, across the healthcare sector, both locally, regionally, and nationally, to make sure that we can help support others become more resilient and join us in that. Particularly in the healthcare sector in a city like New York, which is so complex, we really function as a unified sector, even though in reality we're a bunch of individual hospitals and we operate independently of one another, and some are owned by the government and some are owned privately and some are private nonprofits like our organization. But when a disaster occurs, people expect that there will be a unified healthcare sector response to that. And frankly, we're not set up that way as a community, and so we're trying to help promote that. One of the things that we've done as a part of that is we formed the New York County, which New York County is Manhattan, Healthcare Resilience Coalition in cooperation with the New York City Department of Health and Mental Hygiene, in order to promote that kind of resilience, in order to get not just hospitals, but also nursing homes and long-term care facilities and pharmacies and medical suppliers and all those different organizations and entities that have a stake in the healthcare sector ready to work together, ready to be resilient as possible, so that the next disaster that strikes will have less of an impact on our sector and our ability to provide services. It was important for us to pursue this designation because post-Sandy, we wanted to show that we have a different mindset now, that we're willing to commit ourselves both financially and institutionally to being more resilient. And so this designation puts that out there. It puts us on record as saying we want to make a formal commitment to resilience, and we want to support DRI in this initiative to create additional hubs of resilience, and we want to encourage all of the entities like us out there to think about that. Even if they're not ready to become a hub of resilience, which again is both internal resilience and promoting it externally, they should at least be thinking about how to make themselves more resilient internally. This is an important part of our overall continuity program because we want to be able to serve as that kind of role model so that we're not just focused on our own resilience, but also helping others to become more resilient. Our plans as a hub are to support ourselves, continue to support our own resilience initiatives. Right now, as an internal part of our hub, we are performing a series of resilience assessments for all of our hospital departments, one by one, looking at interdependencies, looking at critical processes, looking at who depends on us upstream and who depends on us downstream to make sure we continue to provide those critical medical services. And on the research side, we're looking at the 250 plus research labs that we have, doing resilience assessments of them individually to see what we need to do to make them better prepared to withstand all types of hazards that may occur to them. And we're doing the same sort of thing for our faculty group practices, our clinics out in the community, as well as the School of Medicine, to make sure that we can continue to provide that exceptional educational learning experience that we do and that our students count on. So that's what we're planning to do as a hub, is continue that kind of assessment internally, not just do traditional business continuity, which to me is far too reactionary after the fact. We're trying to get out ahead of that internally, and then again, externally, continue to promote resilience every opportunity that we can in the community.
Thank you very much, Brad. Finally, we'll hear from John Molnar, DRI International's healthcare lead instructor and managing principal for Integrity Consulting. John, can you give us an overview of DRI's healthcare continuity courses and how they can be applied to developing a continuity plan in the healthcare field?
I appreciate the introduction, Russell. Thank you. Hi, everyone. I just wanted to start with DRI has 2 courses in the healthcare business continuity space. This is about some of the differentiators that the course provides in terms of implementing a successful business continuity program within the healthcare environment. HCP 501, the Healthcare Continuity Review, is a 2.5-day course, and the HCLE 2000 is a very intensive 4-day course going over the attributes of business continuity program. What you get from these courses are not just the basics in the various business continuity professional areas, but what it takes to start, expand, and enable an enterprise resilience structured approach across this enterprise. The next slide goes into the 10 practice areas that the 2 courses work through. These continuity practice areas are core to the makeup of a successful business continuity program. What this doesn't illustrate, however, is the connectivity between these individual areas from an organizational standpoint and a process standpoint to allow you to implement a successful business continuity program. I wanted to go over a couple of these just to illustrate the complexity of the business of what it takes to implement these within a business continuity program. Certainly the program initiation and management, without senior level engagement in a business enterprise resilience program, it really is stopped before you even begin. They need to have the engagement from senior management, both in terms of people being engaged in the program as well as money to implement the program structure to enable some of the structure that we're going to talk about from an organizational perspective and a process perspective. And if I can give you some details here, on number 3, the business impact analysis, you could have in a medical center over 400 various business units and related key processes that you are analyzing within a BIA. Certainly number 5, the emergency preparedness and response areas with all the key emergency operation plans, the annexes, the response guides. Again, you could get over 100 various documents within this space. And then the BCPs, the business continuity plans, relate back to 400, 800, whatever the amount of business units are that you're going to be analyzing the risk areas and the resilience plans and responses within each of those organizations. So needless to say, you are going to be dealing with an enormous documentation process that must be standardized, consolidated, and more importantly, analyzed across the enterprise that you're going to be dealing with. This course and these courses get into that type of organizational and process makeup. The next slide gives you an illustration of at least some of the attributes that are within this organizational structure. The trick is to implement this type of structure in a typical decentralized and often stovepiped environment within the medical center enterprise. The first area, of course, is the governance, the leadership. I spoke about it before. Do you have the budget? Are the senior leadership engaged in the validation process, in the approval process? If I can go down the right side of the chart, which deals with the enterprise resiliency area or the business continuity arena, the first thing that catches your eye within this organizational structure as you sort of segment it into business continuity and emergency management, but over on the business continuity side, do you have the strategy or the architectural structure to enable the approach that you are going to utilize so that you can gain control of all of this documentation that I spoke about before? How are you going to approach those 400 business units? How are you going to deal with that in the BIAs? How are you going to deal with that in the BCPs? And how are you going to approach that so that you can make some headway, and also with the understanding that this is a process. You don't have to get everything perfect the first time through, but you do have to enable the vision to be set of where your key risk areas are, what are the core business units that are key and prioritized and need to be at the top of the list in terms of concern areas and in terms of status of where they sit within your resilience structure. A lot of times what we look at in terms of how to approach this large grouping of enterprise business units is to look at it from the enterprise support functions first. And this is probably one area that within a decentralized structure, at least at the beginning, has their own way of implementing their continuity project and sort of doing this in a isolated environment. How do you pull that out of the isolated environment and get it into a controlled framework that it's integrated? And what I'm talking about here is the support areas include, at least what I see, 4 key areas. One is the IT organization. The IT organization is going to have their disaster recovery plan. How do you integrate the IT's disaster recovery plan into the business continuity approach and integrate that separate entity's work and efforts into some of the core decisions that you're going to make regarding capital investments in technology, processes that have to be integrated, some of the regulation and compliance activities, the awareness and training activities that you need to have. How will you integrate those aspects of the disaster recovery plan into the overall perspective and at least gain some input into how they are handling that piece of the resilience players? The other aspect of this is critical support units. This is going to include critical areas such as the labs, the sterilization departments, the blood bank, food services, the nurses support areas. How do you incorporate those support areas, what interdependencies they have, what core clinical units and hospital units that they have input into and that have an interdependency that without these organizations, a serious enablement would occur in the other business units. The facilities organization, including safety and security, is another area that has to be implemented and at least reviewed within the BIA and the BCP for that matter. Certainly the facility is going to be dealing with such critical points as power, backup generation, gas, oxygen, air conditioning, water. These types of critical infrastructure needs are going to be dealing with, again, another outside organization that the business resilient business continuity program has to incorporate. And that business continuity organization will not be the hands-on responsible party for these outside support organizations. The supply chain organization is a fourth group, dealing with the vendors, dealing with the delivery aspects, the inventory, the supply chain decision points that are made within the business units of how much inventory is on hand and how much is based on a just-in-time type of an approach. And again, that needs to be incorporated into the various key business units and how we are approaching the clinical units, the hospital units. There's a university involved in the assessment, and as well as research departments that are involved or could be involved in this analysis as well. Again, that same type of architecture or strategy also needs to be implemented within the business continuity plan development as well. So as you're dealing with these organizational decisions, you don't have to have a different department for each of these, but you certainly have to have it sectionalized on how we are approaching this mountain of paperwork that we're going to be getting that is determining what our key priorities are in regards to resilience, what our solution sets are in terms of process improvements, technology improvements, or infrastructure improvements, and how do we handle changes, improvements, or process changes that have been incorporated in the hospital environment as we go along through the hospital strategy in terms of expansion within the enterprise itself. Again, going over to the left side, we're dealing with a very similar management arena in the medical center emergency management area. You're dealing with the architecture there as well, or the strategy of how we are handling the emergency operations plan. Are we developing an enterprise plan? Are we developing EOPs for the mission level and then dropping down into annexes at the department and hazard level at the enterprise level? Or are we doing this on a mission-based level? Those decisions need to be made up front so that there is no confusion and no repetition in terms of what the documentation is being developed and how we are tracking that documentation within the organization. Again, more documentation is going to be involved in the emergency response guys, dealing with such issues as fires or chemical spills or active shooters or kidnappings. How are those guides implemented, organized, and ownership responsibilities assigned within those types of documentation within the organization? And of course, the incident command structure will involve the senior leadership. Will they know their duties as assigned? Will they know what to do? And is there enough backup within their organizations so that the organizations can continue and those business units can continue and react and respond in an organized fashion when a hazard or incident does occur within the hospital? And then, of course, you get into the regulation and compliance, the awareness, training, and testing and exercising of these plans need to be incorporated in this process, and the lessons learned. And what is critical within this whole environment are the lessons learned from the regulation, compliance, the training, testing, and exercising, are the lessons learned of where resilience issues had not been thought of, where there's areas of weakness, where there's resilience holes. Have they been incorporated, and how do we handle that change management process to incorporate that back into the BIA process and the BCP process? And that has to be organized and run by a program management organization that is working at a strategic level versus just an organization that is filling out the various paperwork necessary within each of these areas and just trying to maintain the paperwork. Are you actually prioritizing the risk areas within that program management organization? Are you clearly conveying the capital improvements that are necessary to reduce the risk? And are you updating the current risk picture based on these enhancements so that senior leadership, so that the various organizations understand and agree, or at least have a mechanism to talk through the prioritization of those process changes, those infrastructure changes, and those capital improvements that are going to be necessary to input monies into the resilience mitigation program. The next slide is a systems approach to this organizational discussion and sort of shows how the various areas that we just talked through are enable the next area from operating. The key in the middle is certainly the hazard vulnerability assessment. That crosses over both the emergency management area as well as the enterprise resilience or business continuity area, and certainly plays a major part in the business impact analysis of what will affect the business units, what threats and impacts will be necessary to be planned within the business impact analysis, and what processes will not be enabled if those various threats occur. That, of course, is tied into the business continuity plans, and the strategies for reducing those risks are incorporated into these plans, as well as whether that's through process enablement, through infrastructure changes, or through technology changes. And again, those issues get back into where the holes exist, get into the resilience strategy, and through exercises, we see if those resilience strategies have been sufficient to cover various areas throughout the medical center in terms of, do we have the risk mitigated to a satisfactory level, or do we need more resilience inputted into that specific business unit? Again, starting within the hazard vulnerability assessment area, the emergency operations plans are developed, the annexes are developed. They relate to the incident command structure and who is doing what, where, and what those procedures and processes would be in terms of reaction to the incident, and then how we are mitigating those disasters through the processes enabled within the emergency management group. And again, those are tested through the exercises, and any weaknesses or holes are addressed, again, through updates to the EOPs, annexes, as well as to the various detailed plans within those business units. Another way of looking at this same type of picture is on the next slide, where again we talk through how the BIAs relate to the BCPs, relate to the program implementation or the emergency management section, and then the whole differentiator in this discussion here is the change management piece that needs to be incorporated within this business continuity program. So you have the BIAs generating the business process analysis, detailing what organizations do, how those organizations do it with various people, processes, the resources, the interdependencies that those organizations have with each other, and the issues that would be caused by the various threats and the impact areas of those threats, including loss of people, expertise, facilities, supply chain, IT, what we had just spoken about before, the causes of those impacts and the probability of those impacts through the HVA, and then that gets incorporated into the BCPs and the resilience and mitigation activities and the specific plans to react to those threats. They lend itself into the emergency management program implementation of the policies and procedures and the event activation and response and reconstitution activities that are often either in the incident command structure or within the response guides themselves. But what is critical within those activities, and I'll mention it again, is this whole idea of change management. Do we have an organization and a process to handle the resiliency gaps that we find from either the risk assessments, the business continuity plans, from the exercises that we're dealing with? Do we have those incorporated into our business continuity organizational structure? And do we have the process outlined to enable these types of technology improvements or mitigation activities that are necessary to close some of those gaps? Also included in that is, a lot of hospitals change. They buy other hospitals. They incorporate other hospitals into the framework. So those organizational changes, adding new missions, new functions, new technologies into play? Is that incorporated into the business continuity program? How is the organizational handling these? How are they incorporating these new attributes and risk areas that will be included in the documentation? Is it a consistent process? Are they going to be another group that is another one-off, decentralized organization and left by themselves to do their own things? That's what we have to enable, and that's what this whole discussion is about, is enabling those types of organizations not to be taken over by the business continuity program, but at least be incorporated into that program's assessment and analysis and prioritization of where the issues are. The mitigation improvements, what effects have they had within the enterprise itself? The capital investments and what they have done to mitigate certain of the areas. So now, do we have a clear listing within our process of what the 10 top concern areas are as it relates to risk within the medical center? Is there a clear delineation of that? Is there a clear delineation of what capital improvements are necessary to help with those threats? And how do we present that throughout the organization? How is that integrated into senior leadership? How is that integrated into the budgeting process, especially the capital budgeting process? What are the control mechanisms that are in place to get that feedback back, to get that assessment approved and analyzed? And how can we move forward so that those activities are processed in an organized fashion? Certainly there will be arguments on which projects are more important than others. This cuts across the IT organizations, this cuts across the facilities organizations, the supply chain organizations. It cuts across each and every enterprise support area that we're going to be dealing with. And how can we handle that? And it has to be handled in an organized fashion, or it really will be a catch as catch can related to a business continuity insight into where we need to focus our efforts to reduce mitigation problems that we're having. So as a way of summary of what I tried to go through here, there are key success factors that you can look at in a business continuity program to sort of score where they are on a various scale. One is senior leadership engaged? And again, the whole idea of you can tell that fairly quickly with, have they invested in a business continuity program? Are they engaged? Are they involved? But the real point is their money included in this to have a centralized group trying to analyze this and present the risk mitigation activities in an organized fashion across the enterprise, prioritizing those issues as it relates and as it's a concern to senior leadership. Is the organization strategic versus reactive? As I mentioned before, is there a clear articulation of the risk areas? Are you incorporating all of your findings of the risk and the mitigation into the capital improvement process? Is it integrated? Is the IT capital improvement process as they relate to mitigation activities related and shown in context with the facilities improvement processes? And how is that determination made of which ones are higher priority than the others? The other key area is there a prioritization and focus on how we go about all the various business unit assessments as it relates to business impact analysis, business continuity planning? How are you handling all of that documentation in the business continuity area as well as the emergency management area? Are you just generating the plans and putting them on a shelf and not analyzing, not prioritizing, not taking those to the next step in terms of summarizing 400, 800, it could be an enormous amount of business units that you are trying to get a picture of. How are you summarizing those key points into something that senior leadership can really act upon? So are you just focused on generating the plans, or are you focused on putting those into a strategic perspective for upper level management? And then, is there a clear organizational structure and enablement process that integrates these various isolated units, especially within a medical center, and brings those together into a real business continuity organization? Have you incorporated your key enterprise support areas, your business unit risk areas into a consolidated review process that you can enable improvements in the highest impact areas? I appreciate your time today and look forward to those questions or any input you may have on the presentation. Thank you.
Great job, John. This webinar is sponsored by Strategic BCP. Its software enables real-time business resiliency and recovery, ranked #1 by industry analysts for strong product innovation and customer experience. Strategic BCP's built-in intelligence, advanced dependency mapping processes, plan workflow visualization, and integrated mobile solutions benefit all industries. Companies such as Health Partners Plans, Cisco, The Gap, and over 200 others choose Strategic BCP for their business continuity and disaster recovery programs. Visit strategicbcp.com for more information. If your organization is interested in sponsoring a DRI webinar, or you're interested in becoming a sponsor of a DRI event, please send me an email at rwooldridge@drii.org. For those of you who are DRI certified professionals, please note that you have earned 1 CEAP, Continuing Education Activity Point, for attending this event. Now, for your questions. Brad, John, and I are happy to answer as many as we can in the time we have left. If you have a question, you can type it into the box labeled Q&A.
I was surprised to see that the big question that we got early on in the webinar was about ransomware. What is it, and why is it so worrisome?
Well, certainly ransomware is one of the cybersecurity issues that healthcare facilities and as well as other facilities are having. It is certainly the flavor of the day for the cyber criminals. Basically what it is that they gain access to a critical software application and take over the access management control so that the medical center cannot have access to that critical application, whether it's an Epic or something along those lines. They are locked out of it, and it certainly affects operations. It certainly affects the finances. It affects all the various types of units within the organization. One of the reasons that these criminals can get in there is 90% of this is basically through what they call social engineering, that they have tricked people within the enterprise to somehow provide their username, password, information through phishing techniques, I guess they call it, as they keep pounding, and with email addresses that are like one letter off from a valid user email address. And these people just keep pounding and pounding until they actually get this information from internal personnel within the unit. Several ways that the cyber arena has to fix this is basically through an installation of a web proxy. Some of the tools, the main tool that I have seen that has been implemented to try to stop this is a company called Blue Coat. Not that I'm advocating Blue Coat at all, but that is just a web proxy that has been installed that basically puts another line of defense between the web and the application servers, so that further validation and encryption can be put in play, so that the users have more difficulty, or that the criminals have more difficulty in actually gaining access to the true application servers.
Great, thank you for that. Brad, one of the things we didn't really address today was the issue of Joint Commission standards for hospitals. To what extent does the Joint Commission take lessons learned on business continuity into account when improving their international standards for accrediting hospitals and medical centers?
That's a good question, Russell, and I am happy that the Joint Commission in recent years has established a separate standalone standard for emergency management. It used to be wrapped in under the environment of care. What is in there is nothing particularly revolutionary. They expect us to have an emergency plan. They expect us to know how to communicate during emergencies, to train and exercise and have a command and control system. None of this is revolutionary. And most hospitals, or all hospitals, have that to some degree. What I think the Joint Commission needs to work on, though, is actually making sure that people have viable measures in place. We had a Joint Commission survey prior to Hurricane Sandy, and our emergency management program got great ratings. And when the hurricane hit, nothing worked. So we've completely redone it. The Joint Commission came in last December for another survey, and we did great again. But frankly, when they say they want you to have an emergency operation plan, they want to look at the cover and see that it says emergency operation plan. Or if they want to see that you've done an exercise, they want to see the cover page of the actual after-action report. But they're not as interested as they should be in making sure that it's all good. And the people they send out to do these surveys are not emergency managers or business continuity professionals, so they wouldn't know necessarily what they were looking at anyway. So they're off to a good start, I think, with having a standard. We're all working toward that standard, but we really need to make sure that the things being done are going to be effective.
Well, a question related to that is, how does a healthcare system, I mean, obviously, what has gone on at NYU Langone has been, cutting edge, but how does a healthcare system accomplish this level of preparedness without getting hundreds of millions of FEMA's dollars?
It's a fair question. I think that the way we approach this is we talk about the 4 Ps of resilience: people, plans, processes, and the protective measures. The infrastructure improvements certainly fall into the last P, the protective measures. It's great to have that money. It's great to be able to build flood walls and elevate infrastructure and put in redundant power systems. And that's an important part of the portfolio, but it's just one part. So we work on the other 3 Ps as well. The people, we want to make sure we have a resilient workforce. We want to make sure that they know how they will respond, that they'll be able to be prepared at home so that they can come to work, that when they come to work, they're prepared to stay at work for the duration of it, and that they have all those tools necessary, regardless of what the disaster may bring, to be able to carry out their important mission. The process side, you've got to make sure that all your processes are in place to withstand anything that might happen, especially the lifeline services that serve your organization, water, power, other things that you may not control. You need processes in place to make sure you can sustain those. And supply chain, another important process. Your supply chain vendors may do fine during normal times, but during a time of a disaster, we expect them to get the things that we need quicker and under normally very bad conditions. So you really have to think through those kinds of processes to make sure that everyone who does things normally on a day-in, day-out basis and it seems to function properly can also do that in times when things aren't going so well. And of course the plans, I talked about that a little bit already, but the way to become resilient is to have good plans in place so that when disaster happens, people know how to respond. They respond as a team. They respond in a way that ties into what the rest of the healthcare sector is doing and to what the local community is doing. So yes, FEMA dollars are great, and let me tell you, if you get a disaster in your area and you're impacted by it, the FEMA dollars are important. You need to know how to understand the system, become an expert on it, because it's a great opportunity to leverage those funds to make yourself more physically resilient as well.
John, medical enterprises, much more than it seems like some other organizations or other kinds of businesses, have a lot of dependency on the medical systems and equipment, MRI machines, blood filtering equipment. How do you plan for backup equipment, and what are the strategies for planning for backup equipment in the hospitals? Is there a specific BIA structure that would be done differently in this environment?
Yeah, I mean, I think critical equipment, whether it's in the medical systems, in the research areas, I don't think changes the approach on how you do the BIA. That is a fairly consistent process, and those types of equipment would be called out, fairly succinctly within the BIA process. I think what's a more critical point that is how do you handle this, especially with expensive equipment like this that your hospital's not going to have, 2 or 3 of these sitting around because of the expense. I think, I think some of the approaches that we have seen within this area is included in this community of resilience that you happen to be developing, and I think that's one of the reasons for the community of resilience is how do we handle issues like this, and how do we work together through coalitions. And I've seen several of these. Brad certainly has one in the New York area. I know the Houston area and the Texas area has a very robust coalition and coordination effort between various hospitals. I have seen this type of coordination up in the Illinois and Chicago area. I bear with me, I just haven't named them all because I haven't seen them all, but I've seen these groups in actions and these coalition departments. I mean, that is these coalitions and this whole idea of community resilience is set up to handle how do we share resources if a true incident disaster occurs within our area. I think it gets past the hospital intent and how can we basically handle the community aspects of this and work together as a community to solve this issue. I mean, unless the hospital is going to have more capital funding to address this than I think you have, I just haven't seen these types of funds being available within the hospital to have this, secondary equipment on the shelf. I think this community of resilience approach is probably one of the best practices that I've seen to move this forward, Russ.
Well, let's give Brad the last word on this question and answer session. Brad, how is Langone conducting assessments of these interdependencies, not just between pieces of equipment, but between the labs and the other areas of the hospital? Are you guys using a special template? Is there a unique tool? How are you doing it?
We started from scratch, Russell. So we started out with a typical business continuity program, and our director of resilience and business continuity, Mitch Simon, is one of the best in the business. We got him from the stock exchange, so he knows business continuity. But what we found was in this environment, we really need to take a different approach. So we've developed a program from scratch. We do have a template, and the concept is that we first have to figure out what makes up this organization. How do we break it down into the key organizational components? And then we go to each of those components, and we have to conduct a very detailed resilience assessment with them. It's questions that we ask. There are some standardized questions. We want to understand what they have as dependencies, both upstream, in other words, who do they depend on to be able to do their job, and downstream, who depends upon them, so that we can understand if there is a disruption, how it will affect us, and then build in a resilience measure to keep that from happening to the greatest extent possible. So Mitch has done a great job of taking that across our enterprise. We're about 2/3 of the way done with that right now on the hospital side. On the lab side, it's a bit of a different approach. The labs are basically 300 separate individual small businesses that have gotten grants and brought them to NYU Langone, and we're happy to have them. But they're not necessarily as well integrated into the department as all other entities are. So we have to treat them individually. We meet with them. We understand what their lab has, what they do, how they can protect their research, and how they can protect our environment from something happening as a result of an accident or a problem in their lab. So in short, we do have a process. We're happy to share it because we think that we're onto something good. And it's really, I think, the best way to do this. Resilience is about getting out in front of this. I feel like sometimes business continuity sets us up to react. Resilience, we want to stop the problem from happening in the first place, and that's what our focus is right now.
Thank you, Brad. Thank you, John, for answering our listeners' questions today. DRI's healthcare continuity training is offered throughout the year, including the scheduled courses you see here. If you still have questions that we didn't cover, or you'd like to schedule a training for yourself or your team, give us a call at 866-542-3744. A recording of this and all our other webinars is posted on MyDRI. I'm Russell Wooldridge, and this webinar has been a production of DRI International 2016, all rights reserved. Thank you for your attention.